Hi, Dr. Touchan here. Today we're going to be talking about fibroids and adenomyosis. Fibroids are a non-cancerous growth in the muscle of the uterus. They can cause heavy bleeding, pelvic pressure, pain, and fertility issues. Most importantly, it depends on the size and location of those fibroids. Whereas adenomyosis is a condition where the endometrial tissue which lines the uterus grows in the uterine muscle wall. This leads to a bulky, tender uterus, painful period, and heavy menstrual bleeding. The question is, can they exist together? And the answer is yes. Fibroid and adenomyosis actually frequently coexist. A lot of studies shows that they could exist around 40 to 60% depending on the study and the imaging type. So if you have a patient who had extensive amount of bleeding, pain, enlarged uterus, and the fibroids alone, because of size or location, doesn't explain the symptoms, adenomyosis should be suspecting as a coexisting condition. Having both fibroids and adenomyosis significantly affect treatment plan. It makes diagnosis and treatment more complex. Myomectomy alone might not relieve the adenomyosis related pain or bleeding. Uterine artery embolization may help fibroids but could worsen adenomyosis symptoms in some cases. Hormonal therapy might suppress symptoms, but it doesn't remove the fibroids. The treatment plans should be aiming at preserving or not preserving fertility. If the patient wants fertility, we recommend myomectomy with hormonal suppression for adenomyosis, like an IUD or hormonal pills or Lupron. If the patient is not seeking fertility, hysterectomy could be the most definitive option to treat both fibroids and adenomyosis. Treating fibroids alone can leave adenomyosis symptoms unresolved. Patient education is key. We have to explain that one surgery or one treatment might not fully resolve all symptoms. It's a combination of treatment to get the best possible outcome. If fibroids and adenomyosis are both left untreated, complications can be really serious. One, chronic anemia, which can cause fatigue, dizziness, being tired all the time, heart palpitation, and severe cases, the need for blood transfusion. Second, it could cause progressive pelvic pain, affect your quality of life. Third, fertility and pregnancy complication, which could significantly decrease fertility, increase risk of preterm birth, cesarean section, placental issues, and miscarriages. Four, it could cause enlarged, bulky uterus that could be visible by seeing abdominal distension. It could compress the bladder, causing frequent urination, or the bowel, which could cause severe constipation. 5, it could cause sexual dysfunction, like pain during intercourse, decreased libido due to being tired all the time or because of pain. 6, emotional and mental effect on the body, like depression, anxiety, loss of productivity, and even social withdrawal. 7, it could cause, of course, delay and the need for more complex surgery, because larger fibroid and deep adenomyosis make surgery more difficult. It could increase the need for hysterectomy, then uterine sparing procedures, and of course increase the risk of complications during those surgeries. Having both fibroids and adenomyosis can be overwhelming, I understand. But the good news, you're not alone. We have options. Treatment needs to be tailored to your symptoms, goals, and future plans, especially if you want to preserve fertility. Whether that means medication, surgery, combination of both, will build a plan together that addresses all the aspects of what you're struggling and going through, not just one part. The most important step is to take action, because leaving these conditions untreated can lead to a serious complications over time.
The reason why I'm focusing on adolescent endometriosis, and this was a fantastic article, it's actually by one of the authors, Dr. Einerson and Dr. Lee. It's about evaluation and management of endometriosis in the adolescent. The prevalence and diagnostic delay. The symptoms of endometriosis typically begin in adolescence In one registry survey, 2/3 of adults with endometriosis reported that their first pelvic symptoms started before age 20 years, and 21% had pain before age 15 years. In certain cases, adolescents may exhibit atypical presentations of endometriosis and might not undergo laparoscopy, leading to potential underdiagnosis and making it difficult to ascertain the actual prevalence of the disease. Listen to this. Nevertheless, among adolescents seeking medical evaluation, the prevalence of endometriosis appears to be notably high. A systemic review, which means a review of looking at everything, all articles, this identified the overall prevalence of laparoscopically confirmed endometriosis as 62% adolescents undergoing diagnostic laparoscopy for any pain, 75% in adolescents with chronic pelvic pain resistant to treatment, which means they were put on birth control or some type of hormonal medication, and 70% in adolescents with dysmenorrhea. Despite the high prevalence, many adolescents with endometriosis experience diagnostic delay. Adolescents frequently see multiple physicians before receiving a diagnosis of endometriosis, and the younger age at onset of symptoms has been associated with a longer diagnostic delay. Diagnostic delay in adolescents appear to be both patient and clinician mediated.